Routine postpartum nursing care includes understanding the physiological changes that help the nurse manage care for the postpartum client. Client education is a large part of routine postpartum care. Here are our learning objectives for routine postpartum care. As always, using the learning objectives to guide your studying is a great method to prepare for exams. The main goal during the immediate postpartum period is to support the stabilization of the client. Other goals include assisting in a client's recovery, identifying deviations in the expected recovery process, providing comfort measures and pharmacological pain relief, providing the client education about newborn and self-care, and providing baby-friendly support to promote infant and family bonding. Physiological changes during the postpartum period, or postpartum, starts with birth and completes with the return of the reproductive organs to their non-pregnant state, traditionally considered to last approximately 6 weeks. Oxytocin, a hormone released from the pituitary gland, coordinates and strengthens uterine contractions to promote healing after delivery. Breastfeeding stimulates the release of oxytocin from the pituitary gland. Exogenous oxytocin, also known as pitocin, can be administered postpartum to improve the quality of the uterine contractions. A firm and contracted uterus prevents excessive bleeding and hemorrhage. Uncomfortable uterine cramping is referred to as after pains. After delivery of the placenta, hormones, estrogen, progesterone, and placental enzyme insulase decrease, resulting in decreased blood glucose, estrogen, and progesterone levels. Decreased estrogen is associated with breast engorgement, diaphoresis, which is profuse perspiration, and diuresis, increased formation and excretion of urine, of excess extracellular fluid accumulated during pregnancy. Decreased estrogen diminishes vaginal lubrication. Decreased progesterone results in the increase in muscle tone throughout the body. Decreased placental enzyme insulase results in reversal of the diabetic effects of pregnancy, which lowers blood glucose levels immediately after delivery of the placenta. And this is why gestational diabetes resolves immediately after birth. The cardiovascular system undergoes a decrease in blood volume during the postpartum period related to blood loss during childbirth, diaphoresis and diuresis occurring within the first 2 to 5 days after delivery, and rid the body of the excess fluid accumulated during the last part of pregnancy. Weight loss due to Lochia, delivery, and diuresis of about 19 pounds during the first 5 days after delivery. Blood loss during childbirth. For an uncomplicated vaginal delivery, the average blood loss is going to be between 300 and 500 mL, which is about 10% of the body's blood volume. For a cesarean birth, the average blood loss is between 500 and 1,000 milliliters, which is approximately 15 to 30% of the blood volume. Hypovolemic shock does not usually occur in response due to the normal blood loss after labor and birth. This is due to the expanded blood volume of pregnancy and the readjustment in the maternal vascular system, which occurs in response to elimination of the placenta and rapid reduction in the size of the uterus, putting more blood back into the maternal systemic circulation. All postpartum clients will have a post-delivery CBC drawn to help determine the body's response to delivery. H&H levels decrease moderately for 3 to 4 days, then begin to increase and reach non-pregnant levels around 6 to 8 weeks postpartum. During the first 4 to 7 days after birth, WBC values between 20 and 25,000 are common. This is called postpartum leukocytosis, and it is how the body prevents infection and aids in healing. Coagulation factors and fibrogen levels increase during pregnancy and remain elevated in the immediate postpartum period. This hypercoagulability predisposes the postpartum client to DVTs. Nurses need to know expected physiological changes to assess for cardiovascular, blood, and vital sign changes that could implicate a postpartum complication. Blood pressure is usually unchanged with an uncomplicated pregnancy, but can have an insignificant, slight transient increase. Significant decrease from baseline could indicate bleeding. Significant increase could indicate postpartum hypertension issues. Possible orthostatic hypotension within the first 48 hours postpartum can occur immediately after standing up with manifestations of faintness, dizziness, lightheadedness, seeing spots, tunnel vision. Encourage the client to sit on the side of the bed prior to standing up. This will help reduce the risk of orthostatic hypotension. Heart rate and cardiac output increase for the first hour postpartum and then gradually decrease to baseline. Due to elevations in stroke volume during the first 2 days after delivery, the heart rate can be as low as 40 beats per minute. This is called puerperal bradycardia, and this is common finding. Tachycardia in the postpartum period should be evaluated. It is an indication of either pain or hemorrhage. I have never had a postpartum client as low as 40 beats per minute, but I do often see clients with a heart rate in the 50s who were normally in the 70s. So again, it is transient. It is called puerperal bradycardia, and it is a normal finding as long as there are no other signs and symptoms and the other vital signs are normal. Elevation of temperature to 100.4 results from dehydration after labor during the first 24 hours, but should return to normal within that 24-hour period. Elevation after 24 hours or that persists after 2 days could indicate an infection. Postpartum assessments immediately following delivery include monitoring vital signs, uterine firmness and its location in relation to the umbilicus, uterine position in relation to the midline of the abdomen, and amount of vaginal bleeding. The mnemonic BUBBLE-HEE is a useful tool to help remember all the components of a focused postpartum physical assessment. Now we will discuss each of these components. So the first B is for breasts and nipples. Physical changes of the breasts include the secretion of colostrum, which occurs during pregnancy and 2 to 3 days immediately following birth. Milk is produced 3 to 5 days after the delivery of the newborn. It is also important to determine the client's choice regarding breastfeeding. The nurse should perform a physical assessment of the client's breasts, observe for erythema, breast tenderness, and signs of mastitis, observe nipples for signs of redness, cracks, bleeding, bruises, blisters, determine the client's ability to latch on the newborn to prevent soreness and ensure effective milk removal. Nursing care should also focus on promoting early breastfeeding within 1 to 2 hours after birth, assisting with positioning and latching the newborn, teaching proper latch techniques to prevent nipple soreness, advising clients who do not plan to breastfeed to not stimulate breast or express milk. It is important to teach the client the importance of proper latch techniques. The newborn takes in part of the areola and nipple, not just the tip of the nipple, to prevent nipple soreness. That breastfeeding causes the release of oxytocin, which stimulates uterine contractions. So it is normal to feel cramping, like severe cramping that sometimes almost feels like contractions. This is part of the normal healing process. The U is for uterus, referring to uterine involution. During pregnancy, the woman's entire body changed to accommodate the needs of the growing fetus. After birth, the woman's body once again undergoes significant changes to return her body to its pre-pregnant state. Fundal height descends into the pelvis approximately 1 finger breadth or centimeter per day. 1 centimeter per day or 1 finger breadth, which is the side of the finger. Uterine involution pattern is after the placenta is delivered, the uterus should be midline and 2 centimeters below the umbilicus. In about an hour, so 1 hour after delivery, the fundus should be at the umbilicus. And then every 24 hours, the fundus should descend 1 to 2 centimeters. After 2 weeks, the uterus should not be palpable. For the postpartum uterine assessment, assess the fundal height, uterine placement, and uterine consistency at every assessment. When performing the assessment, you're going to apply clean gloves and explain the procedure to the client. Position the client supine with their knees slightly flexed so that their fundal height is not influenced by positioning. Observe lochia flow at as the fundus is palpated. Couple one hand just above the symphysis pubis to support the lower segment of the uterus, and with the other hand, palpate the abdomen to locate the fundus. Determine the fundal height by placing fingers on the abdomen and measuring how many finger breadths or centimeters fit between the fundus and the umbilicus above, below, or at the umbilical level. Determine whether the fundus is midline in the pelvis or displaced laterally, causing a full bladder. Determine whether the fundus is firm or boggy. If the fundus is boggy, which is not firm, lightly massage the fundus in a circular motion. If the uterus does not firm after massaging, keep massaging and notify the provider. Additional nursing care includes administering oxytocin IV or IM after the placenta is delivered to promote uterine contractions and to prevent hemorrhage. Encourage early breastfeeding for a client who is lactating. This will stimulate the production of natural oxytocin and prevent hemorrhage. Encourage emptying of the bladder to prevent possible uterine displacement and atony. The next B is for bladder. Assess the urinary system and bladder function. Assess the client's ability to void. Perineal urethral edema can cause pain and difficulty in voiding during the first 24 to 48 hours. Excessive uterine diuresis is normal within the first 2 to 3 days after delivery. Assess for evidence of a distended bladder. Fundal height above the umbilicus or baseline level. Fundus displaced from the midline over to the side. Bladder bulges above the symphysis pubis. Excessive lochia, or tenderness over the bladder area. Nursing care involves anticipating client needs and education. Assist client to void within 4 to 6 hours after delivery. Encourage frequent emptying of the bladder. Teach client that postpartum diuresis with increased urinary output begins within 12 hours of delivery and is expected and is normal. Teach that urine retention can cause infection, uterine atony, and bladder rupture. And that is why it's so important to make sure they get up and go to the bathroom every 2 to 3 hours to empty their bladder. Encourage increased oral fluid intake to replace the fluids lost during delivery and prevent dehydration. The nurse can catheterize the patient if the bladder is distended to prevent bladder rupture and to allow for uterine involution. The next B is for bowel. The nurse should assess bowel function by auscultating for bowel sounds, assessing for reports of hunger, expect the client to have a good appetite, assessing for flatus, and educating that a bowel movement might not occur for 2 to 3 days after delivery. Assessing for discomfort with a bowel movement related to perineal damage. Nursing care focuses on encouraging interventions to promote bowel function. Hydration is a key factor. Administer stool softeners to prevent constipation. Encourage cesarean client to ambulate to promote passing gas and prevent abdominal distension, bloating, and avoid gas-forming foods. So whatever foods make them gassy, you want them to avoid those. The L is for lochia. Lochia is post-birth discharge that contains blood, mucus, and uterine tissue. The amount of lochia is like a heavy menstrual period and decreases gradually at a consistent rate. The 3 stages of lochia are REEDA, which is dark red color, bloody consistency, has a fleshy odor, can contain small clots. Transient blood flow increases during breastfeeding and upon rising, so gravity. Lasts approximately 1 to 3 days after delivery. Serosa is a pinkish brown color and serosanguinous consistency. Can contain small clots and leukocytes. Lasts from approximately day 4 to day 10 after delivery. Alba is a yellowish white creamy color with a fleshy odor, can consist of mucus and leukocytes, and lasts approximately 10 days up to 8 weeks postpartum. You will need to assess the amount of lochia. Quantity of saturation on a perineal pad. Common descriptors include scant, light, moderate, heavy. Assess lochia for color, amount, odor, and consistency. Note that C-sections have less lochia because the provider cleans out the uterus. Weigh the lochia for an accurate quantitative blood loss, QBL. Nurses will perform interventions based on the cause of abnormal bleeding, such as excessive bright red vaginal bleeding can indicate a cervical or vaginal tear. Foul odor could indicate an infection. Persistent heavy lochia indicates retained placental fragments. It's important to teach clients to change their peripads frequently and perform hand hygiene after perineal care. I often have clients who don't want to waste pads and will use the same one multiple times, but it is really important that we educate them to change their peripad every time they go to the bathroom, and this is going to help prevent infection. You also want to educate the client to notify you or the provider if saturating a peripad in 1 hour or less or expressing large clots. The E is for episiotomy, lacerations, or incisions. For this part of the focus assessment, nurses will assess the perineum. Sometimes the perineum is intact. This means the client did not have any perineal soft tissue damage. More often than not, the client will have perineal redness and swelling, especially in areas of an episiotomy or laceration. There may also be hematomas or hemorrhoids present. You can use the mnemonic REEDA to help remember what to assess and document when observing episiotomies and lacerations. Nursing care will promote measures to prevent infection and soften client stools, encouraging hydration and administering stool softeners. Nurses need to promote comfort measures to help reduce perineal discomfort, such as applying ice packs to the perineum for the first 24 hours to reduce edema and pain. Have the patient lay in a side-lying position to relieve pressure from sitting. Administer pain medication. Have the client use topical antiseptic spray or witch hazel or Tux. Client education will focus on teaching the client to use the peri bottle with warm water after each void to clean the perineal area. And you want to use warm water because the warmth of the water increases circulation to the area. Teach the client to blot the perineum from front to back after voiding. And again, you want them to teach them to blot, not wipe, and always clean front to back to avoid bringing stool into the vaginal area, which then can cause infection. Change the peri pad frequently. Perform hand hygiene after any type of perineal care. When assessing the perineum, it is important to assess for hemorrhoids too. The H in BUBBLE-HEE is for hemorrhoids. This assessment is often forgotten when assessing postpartum clients, but important to help provide suitable comfort measures and education. If your client had a C-section and not a vaginal delivery, nurses can still use REEDA to assess the cesarean incision. Make sure to observe the client for erythema, edema, bruising, drainage, dehiscence, and approximation. Nursing care will focus on preventing constipation, promoting comfort measures, following orders to remove the pressure dressing, and providing education to the client to promote self-care. Client education includes incision needs to be kept clean and dry to avoid infection, patting incision dry after showering, not rubbing, using ice packs to help reduce inflammation and pain, wear cotton underwear and pants to allow the incision to receive air, reinforcing incision care based on closure method. There are different types of closure methods such as staples, steri-strips, Dermabond. So depending on the closure method, we will give specific education. So H in BUBBLE-HEE is for hemorrhoids. Assess the rectal area for varicosities, which are hemorrhoids. Nursing care focuses on encouraging interventions to promote bowel function. So again, hydration is a key factor. Administering stool softeners is going to help prevent constipation and allow for easier bowel movements, especially when a client has hemorrhoids. And then you want to teach the client how to care for the hemorrhoids. So using Tux pads or witch hazel, and avoid sitting on their bottom, which puts a lot of pressure on the hemorrhoids and makes it hurt more. So having them lay in a side-lying position, oftentimes with a pillow between their knees, is helpful. Nursing actions for alterations in findings include notifying the provider and performing prescribed interventions based on the cause of an alteration. Nurses should encourage adequate fluid intake, encourage early ambulation to prevent venous stasis and thrombosis, maintain SCDs on lower extremities while on bed rest or not ambulating. Make sure to teach clients about signs and symptoms of DVT that need to be reported to the provider. DVT is one of the most common complications after having a baby. It does not matter if you have a vaginal delivery or a C-section, but women who have C-sections are more at risk because they had surgery. So make sure that you're always assessing pedal pulses, skin turgor, and inspecting the legs very well for edema, as well as signs of DVT like redness, swelling, and warmth. Postpartum changes involve reversal of adaptations that occurred during pregnancy. Removal of progesterone restores muscle tone. It's important to assess the client's ability to ambulate independently. The nurse should always assist and the postpartum client to the bathroom for the first time, assessing ambulation, but also taking the opportunity to teach perineal care. Diastase recti, we learned about during pregnancy changes, usually resolves within 6 weeks after delivery. During the postpartum period, a client can experience many different emotions due to hormonal changes. Monitor for conditions such as postpartum blues and depression during the postpartum period. We will learn more about postpartum depression when we discuss postpartum complications. Emotional assessment allows for verbalization of client feelings, assessing emotional status, and observing for bonding with the infant. Client-centered nursing care should encourage skin-to-skin contact, document interactions and bonding concerns the nurse might have, encourage rooming in with the baby in the client's room at all times, and provide support and initiate referrals as needed for counseling. As nurses, we always assess pain as part of our physical assessment. To assess pain, we want to know more details, right? Location, type, quality, what makes it worse, what makes it better. So think of your PQRST that we learned. We will administer pain medications as ordered, and always reassess pain level and effectiveness after interventions, whether they're pharmacological or non-pharmacological. We want to know if our intervention works. So make sure within an hour that you are reassessing. We will also teach the different non-pharmacological measures that can help with pain. So for postpartum, this is distraction, heating pads, position changes, cold packs, tucks, lanolin, nipple shields, hydrogels, dermoplast, like a numbing spray for the vaginal area. There are lots of different things that can be used. The postpartum nurse is also responsible for reviewing the status of rubella, RH, and Tdap. With each of these, we do want to give them in that postpartum period before the patient is discharged home. For rubella, patients that are non-immune, they will need this booster. We do administer rubella sub-Q. Pregnant patients do not get the rubella vaccine or booster because it is a live vaccine and can cause birth defects. So we also want to teach this client who gets a rubella booster postpartum to not get pregnant for the next 4 weeks. We would hope that they would not be trying to get pregnant, but crazy things do happen, and it's part of the education we must provide when giving this vaccine is to take precaution to not get pregnant for at least 4 weeks. For ROGAM, if our patient is Rh negative, we are going to check the blood of the cord blood from the newborn. If that newborn blood is Rh positive, this is the indication that mom needs a dose of ROGAM postpartum. This ROGAM will be administered IM, and it needs to be administered within 72 hours of the delivery process to suppress any of that antibody formation. For Tdap, This vaccine is recommended for the client as well as any caregivers of young children, and they should be getting it at least every 5 years. When a woman gets Tdap during pregnancy, the antibodies do transfer to the fetus and they have protection after birth. So it is preferable to get the Tdap vaccine during the 3rd trimester of pregnancy. But if the client did not, and when you review their records, it shows that their Tdap is over 5 years old, they should get a booster before discharge. And this is going to be administered IM as well. So an example of promoting baby-friendly care includes the nurse delaying nursing procedures during the first hour after birth and through the first attempt of the client to breastfeed, and this allows for immediate parent-infant contact. So that is just one example of what baby-friendly care is. A client's emotional and physical condition. So this can be due to an unwanted pregnancy, an adolescent pregnancy, history of depression, maybe a difficult pregnancy or birth, and the newborn's physical condition, which could be related to prematurity, congenital abnormalities after birth, can all affect the family's bonding process. Culture, age, and socioeconomic status are other factors that can influence the bonding process. Bonding can be delayed secondary to maternal or neonatal factors. Nursing assessments include noting the client's condition after birth, observing the maternal adaptation process, assessing maternal emotional readiness to care for the infant, and assessing how comfortable the client appears in providing infant care. So when we talk about baby-friendly care, there is a big push to keep moms and babies together. So whenever we can keep a mom and an infant together, we will. So we try not to separate them or admit babies to NICU unnecessarily if we can keep them together, and that does promote this baby-friendly care. Assessment of bonding and integration of an infant into the family structure requires that a nurse understands the normal postpartum psychological changes the client undergoes as the attainment of the maternal role and the recognition of deviations. There are 3 phases of maternal role attainment. The taking in phase focuses on the client meeting personal needs. The taking hold phase focuses on baby care and improving caregiver abilities, and the letting go phase focuses on the family as a unit. I feel client education is the foundation of routine postpartum care. Discharge planning and education should be initiated at admission and be continuous throughout the hospital stay. The nurse should always use a variety of teaching strategies to promote learning, such as return demonstrations and verbal teachback. These strategies ensure that adequate learning has taken place. Provide client teaching on self-care. So for perineal education, we want to teach the client to cleanse the perineal area from front to back with warm water after each void or bowel movement. We want to blot perineal area from front to back. Use ice packs and tucks for perineal discomfort. Apply a clean peri pad every time they go to the bathroom. This pamphlet or poster that you see here, please read through it. It really does go into great detail with lots of good education. even the warning signs are on here when we talk about not putting anything in the vagina. Don't use tampons, douching, no sex, nothing in the vagina. So this is a great teaching tool. When I do discharge teaching, I literally go through this step by step with my patients. For breast care, so this is breast care for a client who plans to breastfeed. We want to emphasize the importance always of hand hygiene prior to breastfeeding to prevent infection. So breast care will include wearing a well-fitting, non-binding bra. Um, if they want breast support, it is absolutely fine that they wear some type of um, bra, but it cannot have an underwire. So no underwire, because underwires can cause clogged milk ducts. So support bra, some type of lactating bra, everything is fine. It's just nothing with an underwire. You want to allow the infant to nurse on demand, which would be about 8 to 12 times in 24-hour period. Want to allow the infant to feed until the breast softens. Offer the second breast to the infant before completing the feeding, and start each feeding with a different breast. So from here, I want you to remember that an breastfeeding infant should be feeding at least 8 times a day, and that the client should be offering both breasts at every feeding. So even if a infant, feeds on one breast and they fed for 20 minutes, we still want to give them the opportunity to feed from the second breast. They may not want to, or they may only feed for 5 minutes. That is fine, but we need to give them the chance to we have to offer both breasts at every feeding. To relieve breast engorgement, a client can take a warm shower or apply warm compresses before breastfeeding, and this will promote letdown and milk flow. We want to make sure that they empty each breast completely at every feeding, and if a newborn is not doing that, they can use a breast pump if needed. They can apply cool compresses after feedings, but if they're having any pain, but no longer than 15 minutes. There are breast creams that can be used for irritated or cracked nipples. So lanolin is the most common. You can also express colostrum and use that on the nipples. Colostrum is full of proteins and antibodies, so it makes a great healing ointment. Hydrogels are another intervention for cracked or bleeding nipples. For a client with flat or inverted nipples, you can use a breast shield or breast shell. A shell kind of tries to help the nipple evert between feedings, and a nipple shield is used during feeding to kind of give a faux nipple for the newborn to latch onto. And this is for clients with flat or inverted nipples. And then we want to encourage our client to drink plenty of fluids. When they breastfeed, they will get extremely thirsty. So always have a fresh, fresh water at their side when they are going to breastfeed or pump. Clients who do not plan to breastfeed, we call this milk suppression. Suppression of lactation is necessary when they do not want to breastfeed. So, what are we going to tell them? That's different than our other patient that does want to breastfeed. So, this patient, we do want them to wear a well-fitting supportive bra continuously for the first 72 hours. When I think of this, I think of a really tight sports bra. is what they should be wearing. They need to avoid breast stimulation and running any warm water over the breasts, because this will cause the letdown, and that is just going to start the milk suppression process over from the beginning. For breast engorgement, so as they are not emptying their breast, they're going to become full, they're going to become a little painful. They can apply a cold compress for 15 minutes and then 45 minutes off, and they can continue to do that, cold for 15 minutes each hour. You can use fresh cold cabbage leaves inside the bra. There is some enzyme in cabbage leaves that help reduce the pain associated with engorgement. You can give a mild anesthesia like your Tylenol, or an anti-inflammatory medication like Motrin, and this can be taken for pain and discomfort of breast engorgement. Promoting activity and rest. So we want to, of course, encourage early ambulation. This is really important to reduce the risk of blood clots and DVTs. Have them sleep when the infant is sleeping. Eat a balanced diet. Drink plenty of fluids. They should have some help at home, whether it's their partner or a family member, someone to, do some household tasks for them. They shouldn't be lifting anything heavy. And then they need to try to cluster care. So we talk about cluster care. So if you're gonna, dress the baby, feed the baby, try to do everything at one time, right? The baby gets up, you're gonna change their diaper and change their clothes and feed them, and then they're gonna take a nap after they eat. So, reporting potential complications is very important. This is part of discharge teaching, but we will talk about these complications throughout the hospital stay. So, postpartum complications, which we will talk more about next week, but they do include hemorrhage, infection of the breasts, wounds, incision, opening, postpartum depression. These are all possible complications. So we want to ensure the client has an appointment set up for their postpartum visit. Typically, a vaginal delivery will need to be seen by the provider in 4 to 6 weeks from delivery, and for a cesarean birth, they need to be seen within 2 weeks for an incision check. These are some indications that we want to teach the client that they need to notify the provider about immediately. So again, at the hospital, we're there, right? But once they get home and something doesn't seem quite right, what do? They call their doctor's office. So these are the things that we would be concerned about. If they have a fever greater than 100.4, if there's a change in vaginal discharge, so is there an increased amount of lochia, large clots, just any change that goes backwards. So if they've kind of progressed, lochia, and now you're bleeding really dark red again, that's not normal to go back. Episiotomy, lacerations, or incisional pain that does not resolve with pain medication. So again, we think REEDA. So when I teach, I tell them if you see swelling, redness, drainage, if the incision looks like it's separating. So I use layman's terms. So I still teach them to assess it with REEDA. I just don't use our medical jargon. If they have any pain or tenderness in the abdomen that's not relieved by medication, this can indicate an infection. Breast with pain or tenderness, if they have any pain or swelling or redness in a calf. Urination, should not be frequent and urgent and burning. that's a sign of a UTI. And then indications of possible depression. If they stop, wanting to take care of themselves or their baby, or think about harming themselves or their baby, that is something that needs to be reported as soon as possible.